Sunil Jindal sir, and he is a chief consultant at Madhu Jindal Memorial Test Baby Center. He is a laparoscopic surgeon and andrologist and reproductive medicine specialist at Jindal Hospital, scientific director, and he is also a vice chairperson for the Delhi ISA and Delhi IAG. And today he is going to unveil the mystery of demystifying the testosterone. So I request everyone to please have a go through that session, and if you have any query, any questions, please post it in our mail, and we will love to answer your question. Sir, I request you to please, stage is all on yours, sir. Thank you, sir.
Thank you very much. Thank you very much, Vinod, for this amazing introduction. And if you ask me very honestly, it's a very crazy introduction which I have, in the sense that I have 3 children, an amazing wife. I am a surgeon and urologist by training, an andrologist and ART specialist by passion. I have given birth to so many infertile couples, and I would love to have every person without a baby to have babies. And this amazing program which we had formulated was for the prime reason that testosterone is one of the most used, misused, and underutilized hormone. And this hormone, incidentally, is a hormone which needs proper use in so many different areas. So today we are going to basically open up the enigma, open up the Pandora box, and bring it forth to you. This is the basic purpose. I like to So we're going to go ahead with the fact that we would like to demystify. We would like to demystify testosterone. And to demystify testosterone, we need to first understand the history of testosterone. It's very interesting. Nobody knew about testosterone. Nobody had discovered testosterone. But everybody actually thought that and knew that castration has been practiced for a very long time to have obedient servants, slaves, soldiers, and it was used once upon a time for punishment and revenge. So testosterone became a phenomenon and a great hormone for, it was a way out, but nobody really understood that what does castration do? In fact, if we go on to the Victorian times, pre-pubertal castration was done in the 16th and 7th centuries so that they could have choir boys with voices which were beautiful. And it was as late as 1935 that from the bull's testes, a hormone was taken out, and this was known as testosterone. It was 1935. Now let's understand in a nutshell about the physiology. Testosterone is essential for development of secondary sexual characters in males during puberty. And apart from that, this testosterone has various physiological effects on the body, including the maintenance of lean muscle mass, bone mass, spermatogenesis, libido, insulin sensitivity, and glucose metabolism. Now, see, we need to understand one small thing, that most of the testosterone is bound. And this bound testosterone is in the form of about 97% of plasma testosterone, which is loosely bound with the albumin and tightly bound with the sex hormone binding globulin. And the rest circulates in the blood free and unbound. The circulating testosterone is either transferred to the tissues or degraded into inactive products. Now, something for us to understand is, now what are the guidelines for the optical indication for treatment of a low testosterone? Free testosterone is very difficult to calculate. So normally what is tested is the total testosterone. And it has been seen that by the American Urological Association, about 300 nanogram per deciliter is considered as the lower normal, while by the European societies, it is normally about 320. So in case it is less than 320, it is considered that it is low. Now, testosterone is an enigma in so many places, like the male well-being and chemical transmitters, as male infertility, as male sexual health, male hypogonadism, and female sexual health and its role in poor responders. So there are 5 different areas in which it exists. For me to, in 40 minutes, give you all these 5 areas will not be possible. Therefore, what I have planned at the moment is to sit down and go ahead and give you an overview of everything for you to exactly get the way things are. So first of all, let's go to the male well-being and chemical transmitters. There are a few things which we need to understand. And what we need to understand is there are a lot of questions which we have. And these questions are very interesting because one of the questions is, do newborn babies have erections? Do young boys play with their organs? Do adolescents sleep more in prone positions? And why do teenagers need their own space? Why do people fall in love and have a crush? Why do people go weak in the knees when they see a beautiful, amazing woman? Does their entire, and there's a behavioral change in their whole language when something like this happens in young people. Why does it happen? Why do men have extramarital affairs? Why does sex become boring and tedious in middle age? Does sexual inadequacy of 40s and 50s play a havoc with confidence and emotions? And why do men still have sex in their minds even after their age is 60 or 70? Now, all these things and many more questions can be answered by the testosterone story. And its effect in the man's life, in the development of his sexuality, behavior, attitude, and this is all a chemistry which is a chemical warfare. Have you ever been to a restaurant? When you go to a restaurant, the moment you would sit there and you see around, you would come to know who are the people who are in love, who are young people who are courting each other, and where is there a married couple. The moment you see them, you know it's a married couple. I'm sure you would have seen it. Now, why does a courting couple after marriage turn into a married couple? Have you ever thought about it? This is all because of the chemical warfare. Now let us understand this small thing. When a woman falls in love, the hormone which goes out and does everything, the chemical reactions, is dopamine. Dopamine is a hormone which actually also goes up in cocaine addiction, alcohol addiction. Dopamine is the surge factor. In fact, dopamine is also there when you get hooked onto your telephone. Similarly with a woman, what rises phenomenally is dopamine when she's in love. And the second hormone which comes out when she finds the right man, which is not basically the attraction to his beauty, it is the whole persona. It normally, which is the other hormone, is oxytocin. Oxytocin is the hormone which leads to that wanting to cuddle and love. When in a man, what happens? In a man, something else happens. In a man, with oxytocin, what goes up high is the testosterone. And this testosterone goes up high and has a very big attraction to the physical capabilities of the woman. And this is what makes him weak in the knees. But this high oxytocin, let's understand, sorry, testosterone, we have to understand, the moment the woman is his, it goes down. While the woman still has oxytocin up. So we need to understand that testosterone is a sexual, sensual, alluring hormone which leads to an aggressive drive, while estrogen leads to the female receptivity. Progesterone is a natural sex offender. It kills sex drive. Oxytocin is hormonal superglue. It gives people together. It is something which is very important for bonding. Serotonin, it makes you sexually demure and aggressive. It's a different hormone altogether. While vasopressin is a drug which makes us monogamous, which means it influences the rest of the hormones for us to understand that we need to modulate our testosterone. Prolactin, of course, is a nursing hormone, but if it's high, leads to impotence in male. Dopamine is a desired personified. It is, my God, it is the addiction hormone. It is something which just takes you on. DHEA and DHES increase the sex appeal, sex drive, and the orgasm. While pheromones are sexually transmitted through scent, much more in animals than in men. And phenylethylamine is the molecule of love. It makes you romantic inside. Now, this chemical warfare altogether leads to the way we are in our relationships. What makes a man and what makes a man a woman. This is the way it is. Now, testosterone has a role in male infertility. I'd like to come up with this. We need to understand one small thing, that the pituitary gland forms FSH and LH. FSH produces sperms. Testosterone, LH produces from the Leydig cells testosterone. But testosterone is needed by these sperm-producing cells to produce sperms. So if the testosterone is not produced, you will not have sperms. So it's important for this testosterone should be there in a proper quantity, which is of utmost importance. Now, let's try to understand that the drug known as clomiphene, it is a selective receptor modulator which modulates testosterone in infertility. Anastrozole blocks the peripheral conversion of testosterone to estrogen. So this is another drug which is used. Again, testosterone is what it manages. In idiopathic male infertility, there are a lot of empirical treatments which are given, which at times are testosterone modulating. So if we look at the role of testosterone in male infertility, let us understand that in case testosterone is less than 300 nanogram per deciliter, it needs to be treated because sperm production is going to go down. And if the estrogen ratio is high, we need to bring this ratio back, for which we may need to use anastrozole 1 milligram orally, not QID actually, once a day. And at times the LH is down, we might need recombinant HCG, or we might need to use, for that matter, HCG to bring the testosterone back. So testosterone has a phenomenal role, a very major role in sperm production. Injectable testosterone is not to be used. In fact, if you use injectable testosterone, it leads to a mismatch and can lead to, in fact, a low sperm count or azoospermia. So now we come to male hypogonadism. Very common, least understood, least seen. We need to understand now a few things about male hypogonadism. Number one, the prevalence is very high. The prevalence of symptomatic biochemical hypogonadism is in tune of about 26.1% of the population. Hypogonadism is more common and prevalent in older men, in men with obesity, those with comorbidities, and in men with poor health status. Testosterone declines at 1% per year. Some studies report that the mean total testosterone concentration of men at 75 years is about 2/3 of what it is at 25 years. And around men, 20% of men older than 60 and 50% more than 80 at this age have a very low testosterone level, and testosterone over here needs to be replaced. Why? I will let you know. See, we need to understand that the normal axis is when the pituitary produces LH and FSH, it works on the testes to produce testosterone and sperms. There is primary hypogonadism in which the LH and FSH are raised because the testes are not working well. And there is less production of testosterone as well as sperms. While you have a secondary hypogonadism where LH and FSH may be less or could be probably normal, and you have a loss of testosterone. But what we need to understand basically is how does the patient come to us? There is decrease in energy vitality. I'll give you an example. A very famous attorney I know who is at the top of the world, who has a fantastic practice. I got a call from him one day and he said everything is fine, but I feel depressed. I don't feel like working. My weight is going up. मेरा पेट बाहर निकल गया है. I cannot concentrate. When I do my cases, I do not feel, I fail to remember what I used to earlier. My attraction towards my wife has gone down and I feel as if I'm weak. And मेरा fat बढ़ गया है. He further on said that I have visited a psychiatrist and I'm taking medication as an antidepressant, but it is not helping. I asked him to get a serum testosterone done. And in his serum testosterone, the testosterone came as low. I repeated it. It came as low. Started him on testosterone gel. He's taking it now for a year and is absolutely fine. In fact, sometimes he says, you have given me the magic potion. And he, he spoke to me after about a year of taking antidepressants. So we need to understand a few warning signs. If the recovery is low from any kind of injury, if there is nervousness and irritability, if there is a decrease in sexual enjoyment, if you feel that time is running out, I just don't know what to do. If the concentration is down, if there is more of anxiety and fear, if you're feeling fat, if there's a sleep disturbance, if there is sleep apnea, indecisiveness, and loss of interest, you may have a low testosterone. Now, how does it go down? See, the first thing which happens is that there is loss of libido. Then there is increase in fat. Then people have depression. And then there is erectile dysfunction. This is the algorithm, which is a long algorithm. Along with this, there are 4 more algorithms which are there. So I think I'll go through this algorithm. I'll go it shortly. That you have to, in hypogonadism, see rest other things if they are there. If there is depression, hypothyroidism, apnea, anemia, you have to rule all of those things out. If it is still there, you check the morning sample for testosterone. If the testosterone is down, you repeat the sample. If it is there, you do the E2 ratio. If it is fine, put the patient on testosterone, reassess after 3 months, see if the patient has improved, and you can continue testosterone in these people. Now, you need to understand the duration of treatment. It is about after 3 months that there is an enhance in libido, emotional well-being, energy, and erectile dysfunction becomes better. Strength BMD, cognition, metabolic, fat, they all take about 6 to 12 months. There are a lot of preparations available. I will not go into the details at the moment, but what I'll tell you is very simply. The problem with injection is the peaks. And the problem with oral is the hepatic metabolism, and along with that, the hepatotoxicity. So the best thing to use is a testosterone gel. And why? Because it keeps a steady concentration and it requires daily administration, does not disturb serum lipids, there is good tolerability, it has an advantage over the oral administration as far as the liver is concerned, and there is a greater flexibility which you have with a gel. Now, how do you give a gel? The gel is given in the form of either sachets or in the form of a pump. So the normal dose for a man is about 50 milligram. 50 milligram, one pump actuation is about 12.5 milligram, which means you have to get 4 actuations and apply it on any part of the body. It is not to be applied on the scrotum, which a lot of patients feel it needs to be done. In case, and you have to monitor these patients regularly with testosterone, if the testosterone is normal, fine, has not increased the way you want it to, you could increase it to 75 milligram, and the maximum dose which you can give is about 100 milligram, which means about 8 actuations. Now, sexual dysfunction. We need to understand that this is something very common. And sexual dysfunction takes place in mid-age in about 50% of people by the age of about 55. And by the time these people reach about 70 to 80 years, about 70% of people have erectile dysfunction. Now, what we need to understand is that the mechanism of action is arterial dilatation, there's filling of the sinusoids, there is venous compression, because of which the blood doesn't go back. But something for us to understand is it is like a sink. In the sink, you have filled up water, which means the arterioles have opened. You have put a bung to let the water from going back. The sink gets full, and when you remove the bung or the bulb below, the water flows out. So this could be because of either a problem with the inflow, or a problem with the sink, or a problem with the outflow. Now we need to understand one small thing, that apart from the opening of the sinusoids, testosterone has a major role in this. And apart from all these things, testosterone is something, if it is low, not only leads to loss of libido, but also erectile dysfunction. Now, there are a lot of pharmacotherapy which has come now, which is PDE5 inhibitors, which are most commonly used, sildenafil, tadalafil, oral prostaglandins are used, L-prostadil is used, injectable phentolamine is used, transurethral alpha-prostadil is used. But something which I was wanting to bring over here is that in hypogonadal men, the number of erectile events per day, rigidity, number of erections significantly improves if a patient with low testosterone is given testosterone. It is seen that in hypogonadal men, replacement needs to be given with testosterone, even if you want to give them sildenafil or tadalafil. Now, these studies, the first 2 studies are studies which were older studies, but the new study which is most important is, I get a lot of patients who have been taking sildenafil over a period of time. And these patients now do not get erections even with sildenafil. You get a testosterone ban, the testosterone comes as low. And in these patients, when you give testosterone gel, they come back to the way they want it to be. So it's very important for us to understand that if the testosterone is down in erectile dysfunction, testosterone needs to be given. Now, the role in female sexual health and role in infertility, it's a very important role which is there. And this I would touch in a nutshell at the moment, for the prime reason that this actually is just, I would call, introduction to all that testosterone is. But each one of them, which means male fertility, which means well-being and hypogonadism, sexual health of male and female, and poor responders, would need one full day or a full hour, where I could explain to you the etiogenesis, the way we would like to use it, what is the use of other drugs with testosterone, how are they combined, how to use them to enhance value in the life of the patients would be there. And this is something which I would like to cover up in a series of episodes, which INTAS has been kind enough to come up with. So in women, testosterone in low dose has been given, and it has been given in low dose to women who have a low libido. And there is a very big Brazilian study in which they have found significant advantages of using this. The second place where it is used beautifully and it's been proven is in poor responders where testosterone is used for good results, because testosterone is given slowly over a period of time before stimulation, so that the milieu of the ovaries is testosterone rich. See, we need to understand that the ovaries need testosterone for ovulation. And this was the reason DHEA is given. This is the reason where testosterone is given. And this is a beautiful topic to be covered, which also would be covered. But basically, if we look at the whole milieu of testosterone, it's used in hypogonadism, it's used in male fertility, it's used in female infertility, and erectile dysfunction needs a separate lecture each with other drugs with which it has to be combined to give advantage to the patients. So this is the way I would like to bring it further on for you. And I'd really like to thank you for being here for this topic, which is so interesting, and there is so much in which needs to be given to you. Thank you very much. Vinod, over to you, please. Satpatiji.
Thank you, sir, for such a wonderful talk. I think explaining a hormone like testosterone, testosterone, demystifying testosterone in just one session is next to impossible. That is the reason why this is just an information for all the viewers that we have created a series of events for this to really demystify this hormone, the wonder hormone testosterone. So we will be conducting 4 more webinars in series, and we would be taking one particular subject for webinar. So the first one is hypogonadism and the men well-being. The second one is medical treatment of male infertility and role of testosterone in that. Then the third one is male and female sexual infertility, and fourth one is the use of testosterone in poor responders in the active treatment. So the dates are already been finalized. My colleague would be it's already there in the slide, if you can see. However, we'll be circulating the dates to all of you. The next one, hypogonadism and the male well-being will be conducted on 13 June. And the most interesting thing is, post these events, along with Dr. Jindal, we have created a beautiful literature which contains all the details about the talk, all the references available on this topic, and whatever data we can accumulate from our side, and this will be circulated among all the viewers. But question is, we will be giving this to only 500 registration which has been done prior to the webinar. With this, I would request, there are a lot of questions which has come up. So, Dr. Jindal, I would take some of these questions.
Satpathy ji, there are a series of 4 which are there as you had decided and we were sitting back.
Yeah.
And the first on 13th would be hypogonadism and well-being, how to treat.
Sure.
The next was medical treatment of male infertility, which was on the 20th of June.
Sure.
The third is on male and female sexual dysfunction on the 27th of June. And the last would be poor responders and testosterone on the 4th of July, just the way it was. So there are a lot of questions which I believe would be there at the moment.
I think there are a lot of questions which have come up, but I would select some of the questions which I would request you to please address. The first question is testosterone safe for diabetic and hypertension patients?
Okay, it's a very interesting question. And it's a very interesting question for 2 reasons. That the link between diabetes and testosterone is very well established. Men with diabetes have about 2.5 times the chances of having a low testosterone. And men with low testosterone have a chance of having diabetes. So what happens is that testosterone helps the body tissue to take up more blood sugar in response to insulin, which means men with low testosterone have insulin resistance and they need more insulin to keep blood sugar normal. So as most of these people who have low testosterone have diabetes, and those with diabetes have low testosterone, if the testosterone is down in a diabetes patient, you need to give him testosterone. This is the answer for this.
Thank you, sir. What is the use of testosterone in female?
I beg your pardon?
What is the use of testosterone in female?
Yes. See, the testosterone is used in female for 2 things. Primarily, we need to understand that the ovaries of the woman need to have a rich testosterone milieu for eggs to produce. So in people who produce less eggs or ovulation is low, in these people and in these patients, when you give them DHEA or now testosterone, the milieu improves, and then when you stimulate the patients, they respond better to produce better eggs. This is the role of the testosterone. There have been a lot of studies which have taken place where they give testosterone in low sexual libido, which means those people who have low libido and everything else sexually appears to be fine. Though this has not been proven, it's in a very small dose when testosterone is given, the libido improves. So this is being used.
Thank you, sir. The third question is, how do we use testosterone gel in men over 50 to increase libido and muscle mass?
Great question. Great question, because the use of this is in about, over the age of 60, about 25% of people actually need it. So what you do in these people is, you first of all take a history. In the history, if the libido is down, erectile dysfunction is there, they feel listless, they have obesity, muscle mass is down, bone mass is down, you do a testosterone. And if the testosterone level free comes below 320 or 300, you repeat it again. In case it comes as down, start him on testosterone gel. Now, the dose of testosterone gel is about 4 actuations, which means about, you need to give about, 1 actuation has 12.5. So what you need to give is 50. To give 50, what you actually need to give is about 4 actuations of this testosterone gel, which normally is placed on different areas of the body. It can also be given in the form of capsules. It can also be given as injectables. But the problem with both these is, number 1, the convenience of use, and the capsules can lead to hepatotoxicity. And the injections have a up and down peak, because of which the stability does not remain. That's the issue with this. So that's the way you normally would give. And you would monitor this patient for PSA. You would monitor this patient by hematocrit to see what the hematocrit is. And you're going to monitor these patients regularly at interval of 3 months and 1 year. And that's when you would judge whether it needs to be continued or not.
Thank you, sir. The next question is, has testosterone has any role in prevention of obesity?
Well, this is a fantastic question, because see, obesity and low testosterone are very closely linked. Obese men have low testosterone, and men with low testosterone are obese. And fat metabolism is such that it metabolizes testosterone to estrogen, lowering testosterone levels. And also obesity reduces the level of sex hormone binding globulin, a protein that carries testosterone in the blood. And less of this means less of free testosterone. So losing weight through exercise enhances testosterone. And if your weight is more and estrogen is normal, you can give testosterone gel. That's the way it is.
Thank you, sir. The next question is, role of testosterone in management of metabolic disorder and erectile dysfunction.
You know, metabolic syndrome is a name which normally is given for the presence of abnormal cholesterol levels and high blood pressure, waistline obesity, blood sugar. These are the metabolic diseases, and they increase the chances of heart attack and strokes. Now we need to understand one small thing. The studies have shown that men with testosterone are more like low testosterone are more likely to develop metabolic disorders. And in short, testosterone replacement improves blood sugar level and obesity in men with testosterone, with low testosterone. However, testosterone may increase the heart disease. So, you know, it's a very two-edged sword. But in case you feel that the cholesterol is out, the man is obese, the testosterone is low, because see, we need to also understand one small thing. And something for us to understand is that testosterone also gets converted into estrogen, which is heart protective. So in case the testosterone is less, we can go ahead and give these people testosterone. But we have to be very cautious about the heart disease.
Thank you, sir. The next question is, role of testosterone in treatment of female sexual dysfunction and its advantage over tablet and patches.
Can you repeat it, please?
The role of testosterone in treatment of female sexual dysfunction. And is there any advantage over tablet and patches? I'm not sure what tablet.
Okay. See, we need to understand that there is a very big role of testosterone in female sexual dysfunction, but it has not been proven a lot by papers. So by literature, it is still to be proven. And the dose is very small. The dose is about 400 microgram, which means probably one actuation for 4 days. I mean, one actuation a day and repeated after 4 days. So this is still something debatable, number one. Number two, oral is not the answer at all, because the dosage of oral is different. So it's nothing oral. If at all it is to be used for this purpose, it is to be used for 15 days or a month. And you have to see the effect of this. And this drug needs to be used as a gel only. That's the way it is.
Thank you, sir. I think there's a lot of more questions there available there, but we won't be able to take all these questions because I see most of those questions are related to the topics which we have planned for our next webinar.
Great.
So we'll leave it to the audience so that they can join us for the other webinars where we will be talking specific to one particular subject. And probably the discussion would be very clear during those webinars. I would like to thank all the participants for taking out their time and joining this webinar. And once again, a big thanks to Dr. Jindal for accepting our request and conducting this webinar. Thank you so much, sir.
I'll thank all of you for being here, and I'll also thank you for the reason that this beautiful hormone which was extracted from the testes of the bulls, you now understand why bull is so aggressive. See, you need to understand that probably seeing the aggression of the bull, the man decided, I'm going to extract it from the testes of the bull. And believe me, because earlier the only thing known about fact was that if you cut off the testes, the man becomes obedient. If you cut off the testes, these men have beautiful voices for choirs. Then probably the man and the scientists saw these bulls and decided that aggression lies over here. And that's the reason he took out testosterone from that. This beautiful hormone has 4 different areas to be touched. Please be there with us. I really appreciate all of you for having been here. It's been a wonderful evening. Thank you very much. Thank you very much, Intas, Mr. Satpathy. And thank you very much, the beautiful audience whom we have over here. Thank you.
Thank you so much, sir.